Hello viewers. Well, today, as I said last time, I'm again back with a different kind of presentation. Today I'll be moderating a session and one of my residents would be presenting a case. This case has got a very common presentation which you come across when you're sitting in the OPD or in the wards. But well, you must know sometime there could be an uncommon cause to a very common presentation. So may I ask Harsh to start the case.
Thank you, sir. Good evening, audience. Today I am presenting the case of a 5 years, 7 months female presenting with the complaints of difficulty in taking food, vomiting on and off, and not growing well since last 3 years. So, coming to the description of the complaints, the patient has a normal and eventful institutional delivery. She was apparently well for the first 2 years when she was on breastfeed and top milk feeds. She started having difficulty in taking solids as well as liquids.
So the point which I want to highlight here is that when the child started taking solids, so this child was on milk feeds and the breastfeeds till 2 years of age. At that time the child used to vomit off and on, as I asked the mother, but she said it was passed on as a normal. Beech mein ulti hota hai, so that is what normally in children it does occur. So it was thought of, but then the problem mainly started when the child was introduced with the solid foods, right?
So, coming to the description of the vomiting contained food particles. It was non-bilious, it was non-blood tinged. There is a history of massaging her throat above downwards after taking food. And there is a history of not gaining weight as well as height for the last 3 years.
Now, very importantly again here, that it was so much a problem of not taking food that the child used to massage from above downwards. This is what she used to do. Though I understand, it was basically more, you see, it is in the esophagus and the child is massaging here in the interior part. But it was so much stuck that the child used to do like this. It is not going to help in any way, but she used to do this way, right?
So, there was no history of any loose stools, abdominal distension, pain abdomen. There was no history of any corrosive ingestion, trauma to head and neck, foreign body ingestion, and also no history of recurrent chest infections, foul smelling breath, and particularly there is no history of lack of lacrimation during crying.
So may I ask some of them, I'll ask the residents because I find it here, why I have taken all those histories. These histories are important. You have a child of dysphagia, right? And I would not, I'll dwell into it that why we are asking for a child with the lack of lacrimation during crying. Cases of a dysphagia, and there are so many no histories are there, and last but not the least is the no history of any lacrimation during crying. Is it something important which you want to rule it out? Okay. I will discuss this part. Specifically, this was for a disease, and I would discuss it when I am going to the discussion of this case. Then I'll talk about it. Right? Aage chalo.
So, coming to the past history, child was getting treatment from various local practitioners, including pediatricians, and advised various medicines leading to temporary symptomatic relief. Child is developmentally normal for her age, and child is also immunized as per her age.
Just at the outset I said, this child had been going from pillar to post. This child had come to us at the age of 5 years, 7 months. And this child had been having problems since 2 years of age. And the child, I saw the OPD papers of this child, mother had those papers. And I am sorry to say, this child had gone to various doctors, even pediatricians. What I want to highlight here is that you need to, if the problem is so prolonged, you really need to sit down for some time. I understand the OPD is very busy, you don't pay much attention, but that does not mean that you miss out the important things. So that is why I am presenting this case, that you must keep in mind certain important things. Next.
So now coming to the examination part. So coming to the general physical examination, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy and edema. These pictures were absent. The height of the child was 93 centimeter and the weight was 11 kgs. The height for each fell in the less than 3 standard deviation. The weight for each was less than 3 standard deviation, and weight for height was less than 2 standard deviation. And also, their upper segment to lower segment ratio was found to be 1.1.
So based on those examination findings, you can clearly see this child is 5 years 7 months, and this child weight and height are less than third standard deviation. So what was this? This child is a short stature. Upper segment lower segment ratios is almost, it is 1.1, which should be around of the same at this age, that is at the age of 5 years 7 months. Now this child of a proportionate short stature having dysphagia for 3 years, this child landed up in the Baba Saheb Ambedkar Hospital, and luckily it was with Dr. Kaushal. So doctor, now would you like to say, if I ask you people, would you like this is a pathological case or a physiological case? Krishna Rao, you would like to say something? It looks like pathological or physiological? You've seen the child's height, weight is also less than that. Do you think this child is having some pathology or it is normal? Pathological. Why are you saying it is pathological? That means the child has not been thriving well. So child is having problems, not thriving well, is short statured, and has been having dysphagia, which has been going on for 3 years. That is why this case was, then I discussed with Dr. Kaushal, and then it was finally found out that some pathology definitely is there. For that, we tried to find out we need to find out a cause. And as I said, no one had done in the last 3 years. That is why I am impressing again and again that you really need to see. If a child has not been thriving well, not doing well, having problem of the dysphagia, then you must keep in mind. Just don't kalana, OPD mein, you're just giving a date and date, it doesn't matter. You see what happened when I saw those papers, somebody has given either a domperidone or MSET or protein pump inhibitors. They were all given by all various doctors. There was some temporary relief, and then again the child used to have this problem. Next.
So now coming to the systemic examination. On examining the systemic examination, the CNS and respiratory system, there was no any disability. The CVS, CNS, respiratory and para-abdominal examinations were normal.
All systems are within normal limits. Only thing was the general physical examination which has been told. Now we are coming on to the investigations.
So let's come on to the investigation. The complete blood count picture, the hemoglobin was 9.2 gram per deciliter, TLC was 9100 per deciliter, and platelet count was found to be 5.5 lakhs per deciliter. The serum electrolytes were 138 milliequivalent per deciliter, and the potassium was 5 milliequivalent per deciliter.
So all these investigations were carried out. Now the question starts. We are discussing. So I'll ask one by one my residents. This is a child with dysphagia, not thriving well. So would you tell me some differential diagnosis of dysphagia, Vaishnavi? Isko do thoda sa. Tell me, this is a child of dysphagia. 5 years, 7 months. Could see the picture. This child was having short stature, not doing well. And as you also said, that there is some pathologies there. I am broadly asking you, any one of the residents might tell me what are the various causes of dysphagia. Anybody would like to vouch? एक एक करके दो, उसको दो आगे माइक. Sorry? Tonsillar enlargement. Tonsillar enlargement, okay. Esophagitis, usually what happens in esophagitis, usually it starts with regurgitations. Am I right? After the reflex esophagitis, then there will be some kind of a structure, you can say, or then only there will be problem of dysphagia. So esophagitis is there, but not, I think it will be very low down, that esophagitis, there has to be something like now the question is, this is what I was pointing out, GERD or GERD disease. A problem here, you see, this is the likely diagnosis which all doctors had made. The difference here is that here the chief complaint was of dysphagia, and then there was some regurgitation or vomiting. That's what it was said. In GERD, what happens is usually it starts the other way around. You have more of a sore eructation, you have water brash, you have chest pain, you have recurrent chest infections. So those kind of things occur first, and dysphagia may not be there, and dysphagia, as she said, maybe at a very later date that dysphagia would occur. So common would be, we are all in the pediatrics age group, the common things we start from the neurological examination. You would have seen many cases of, we have insisted that there is no history of any, developmentally the child was normal. So most of the cases you come across is the cases of cerebral palsy. If you have a case of a cerebral palsy, there will be problem of the sucking and swallowing. So what is going to happen is that there will be some kind of a, they make some kind of a posture, then there is a problem of taking food well, and then sometime you try to put it on the posterior part of the pharynx so that the child could take the food. So those is the other things are the dystrophies, myopathies. So those kind of things are the congenital problems. As somebody said, I think Vaishnavi said, sometimes, not very commonly, but yes, if you have the adenoid and tonsillar problems, there could be, but that will not last for 3 long years. 3 long years is too long a period for adenoids and tonsil problems. You can have cleft lip, you can have cleft palate, and as she also said, there is something called as esophagitis, eosinophilic esophagitis. So that is one thing, yes, you're right, but common things common. You should always make common things common. So common thing, here at the outset I said some uncommon cause of a very common presentation. So that is why I thought I'll discuss with you the differential diagnosis of dysphagia. So they are the common cause of dysphagia. Next, what did you do the investigation?
So after the basic investigations, we move on to the radiological and endoscopic evaluations. Coming to the first, let me describe the endoscopic evaluation. In the endoscopy, we found a circumferential narrowing of esophagus seen at 20 centimeter, causing complete luminal compromise. There was no evidence of any foreign body, and there was a tight esophagogastric junction, the scope, beyond which the scope could not be negotiated.
So the important thing is, as I said earlier, if the problem is so prolonged, somebody would have asked for an endoscopic examination. Endoscopy is mandatory. Why? Endoscopic examination will tell us a lot of things. Like it is mentioned, there could be some foreign body which is sticking onto the esophagus. So that could also be found out. Here what they found was that there was you will see the next slide, the esophagus was all dilated. There was a kind of a stricture here and it could not be negotiated. The scope also could not be negotiated. So those kind of findings we found it in the, so next step what we did was, it was luckily possible here that we did a swallow study or a contrast study for a barium swallow. Of course, the barium was not here. Luckily, I mean, it may not be there. But what we did was with the water soluble dye, we tried to do the swallow. Just show the slide. Here is the slide. So that is very important. That in this slide, what do you see? Very importantly, just focus on it. That you have a very dilated esophagus and you have a bird beak appearance. The beak is little long, but then as I was reading my literature, there are 3 types which are mentioned. This is called Achalasia, Cardia. So this is Achalasia, a case of an Achalasia, not very common, but you must keep those things also in mind. That at times, especially when there is a growth faltering, child not thriving well, and along with it, it is all less than 3 standard deviation, growth, height, weight, child not doing well, right? Now in such a case, this is called Achalasia cardia. Now I mentioned there in the history of the absence of there is no history of absence of lacrimation. Why did I ask that, Sushma? एक syndrome होता है, that is called triple A syndrome, right? That is called A lacrimation, Addison's disease, and Achalasia cardia. Now that is what I took that history and investigations we got even the serum electrolytes done. Because what is going to happen is if you have an Addison's disease, Ansar, if you have an Addison's disease, what electrolyte abnormalities would occur? Tell me. Just stand up. Tell me in Addison's disease, what electrolyte abnormalities occur? Hyperkalemia, very good. And what happens to sodium? Yes, it is hyper. Why it is there? Because there is no production of the aldosterone. So aldosterone is not there. So what is happening is that you have hyponatremia and hyperkalemia. So that was almost ruled out. Now the question is, I was just reading my literature. In this AAA syndrome, something can present now and something may present out of these three can present many years later. So basically you need to have a molecular diagnosis which needs to be done for a AAA. This child only presented to us with achalasia, that is dysphagia, and that was what we did. Anything else we did?
So we did the endoscopy.
So, okay, now the question is of the treatment modalities. Now regarding the treatment modalities, first of all let's talk about the drugs. The pharmacological agents, anybody can say, basically pharmacological agents are the nitrates are sometimes helpful, or tell me something else. Calcium channel blocker, very right. So Dr. Vikas is rightly saying calcium channel blocker. You can have diltiazem, you can have other calcium, they can be some help. The child has received lot of, as I said, ondansetron, MSET, erythromycin, all they are prokinetics, but sometimes they can help. What are the other drugs? The other drug is now one thing I forgot to tell you, the most important investigation, which I did not mention here is the manometry. The high resolution manometry is the answer for the achalasia. So that's called HRM. That tells you what is achalasia. Achalasia, there is a degeneration of the myenteric plexus. So what is happening is at the gastroesophageal junction, it is not opening up. It is all collapsed. There is a degeneration of those plexus. So what are you going to do is, at that site, you try to find out the manometric pressures and you find out the peristalsis. So high resolution manometry is very important. That is the first investigation. After that, once you have confirmed, then what you do is, I said pharmacological agents. Then the other thing is you can put the botulinum toxin at the site so that it can release the spasm. So injection of a botulinum toxin, or sometime what you do is basically what has been done here in this child also, we referred this patient to the Pant hospital where one of the gastroenterologists has done a pneumatic dilatation. So the pneumatic dilatation has already taken place in this child only once. After seeing this child, after seeing these investigations, they confirmed that this is a case of an achalasia. They did pneumatic dilatation. Pneumatic dilatation once is not enough. You have to do the repeated pneumatic dilatation because there is a likelihood that this child can go in for a stenosis. So once dilatation was done, child was alright for some time, but again this child has again got the same symptoms. As I said, you may have to have repeated dilatations. Now what are the other things? The other thing is the myotomy, because myotomy is of two types. One is a standard type which is called Heller's myotomy. So Heller's myotomy is little more invasive, and now a new thing has come which is called as POEM. It's called POEM, POEM. POEM is per operative, per oral endoscopic myotomy. So it is very good. It is less invasive and it serves the purpose. So maybe certain patients they get all right with a procedure called POEM. So that is all about the treatment which I wanted to say. Pharmacological agent, injection of botulinum, and then the myotomy. And pneumatic dilatation, which has already been done once, and maybe the child will have repeated. Yes, manometry has still not been done, but yes, manometry also is the main crux of the investigation. So the carry home message is, to cut the story short, is don't when you are sitting in the OPD or in the inpatient, try to see the child as a whole. If you have a child who is not thriving well, just keep in mind some pathology is there. And you can see the child in front of you running around from pillar to post for the last 3 years, 3.5 years. And now the diagnosis has been made.